Germany, and he is a visiting fellow in pediatric neurosurgery and craniofacial surgery and women and children's surgery and ACFU Adelaide, South Australia. He, at the present, he is the head and senior consultant neurosurgeon at Department of Neurosurgery, Tunku Abdul Rahman Neuroscience Institute Hospital, Kuala Lumpur in Malaysia, and head and senior neurosurgeon at Department of Pediatric Neurosurgery Hospital, Tunku in Kuala Lumpur. Apart from that, he holds membership and honorary post of various societies. He is the second vice president of Asian Australasian Society of Neurological Surgeons. Then he is World Federation of Neurological Society. He is executive member of Neuroendoscopic Committee and Fundraising Committee. The ISMINS, that is International Society of Minimally Invasive Technique in Neurosurgery. Is active member of World Academy of Neurological Surgery. He is executive member of Asian Congress of Neurological Surgery and audit committee member of Asian Australasian Society of Pediatric Neurosurgery. And apart from that, he is also a coordinator editor of Asian Journal of Neurosurgery and editorial board of Journal of Neuroscience in Rural Practice in Nepal Neuroscience Journal. Apart from that, he is a teaching faculty in various societies. And more than that, he is a wonderful chairperson who's a mentor of Asian Congress of Neurological Society, Young Neurosurgeon Committee, and he is always actively involved in training of young neurosurgeons. So today we'll have Professor Azmi Alias, and he'll be talking about the endoscopic neurosurgery for young neurosurgeon. Over to you, Professor Azmi Alias. Before that, I would just want to tell that today we have Professor Dev Pujari, who is the chairperson of Neuroendoscopic Committee of WFNS, and Professor Alberto. He is the member of Young Neurosurgeon Committee and Education Committee of ACNS in our panelist list, who will be chairing this session. So, shall we start the session, Professor?
Thank you, Sachin, for your kind introduction. So I will start my slide. Okay. All right, can you see my slide?
Yes, Professor, we can see
Okay, it. Okay. Thank you very much again to your kind introduction and invitation. My great honor and pleasure to have Professor Joe Pujari, who is also the chair of the World Federation Neuroendoscopy Committee and Neuroendocrine Committee. So I also pleasure to have Professor Alberto to be in the panelists. So I would like to divide my presentation today into two components. One, we talk about the principle of cranial neuroendoscopy and how do I choose equipment, some basic steps, because I believe that this session will benefit most of young neurosurgeons or the beginners who just about to start or want to upgrade their skill in terms of cranial endoscopy. And second part, I will share a few case illustration where I can share some basic technique and tips and tricks from basic to complex procedure. So this is a hospital where I work. It is located in the city of Kuala Lumpur, about 3 kilometers from the Twin Tower. It's a 150 years old hospital and 50 years old hospital center, which is our Neuroscience Institute, Tunku Abdul Rahman, located in one corner of this hospital. So we also have our new hospital, Children's Hospital, which is located within the same hospital compound, which completely built in July 2018. So practically, most of my neuroendoscopic experience are mainly involved in the first part, which is Tunku Abdul Rahman Neuroscience Institute. Now we have a new hospital where we also develop a lot of neuroendoscopic procedure which involve in children. So I also have the opportunity to be trained and spend almost 1 year with the late Professor Axel Penensky in Germany, where they have a tremendous development, equipment, and technology. You can see when I joined there, this is about 15 years ago. In fact, at the back is a MKM first generation of Carl Zeiss robotic navigation microscope. It's very huge, and they have intraoperative CT scan. This is a prototype of exoscope from Olympus. So they have a wide range of endoscope where I was exposed But when I came back, so this is what I have. So sometimes it's quite important to have exposure in a big center or learn from important person and establish a teacher. But when you go back to your center, you need to know what do you have. So I have no choice when I started endoscopic procedure. I came back in 2005. If you look at that, this is what I have. We gather a Sony television, 14 inches, very old. I think about 15 years old. And we get light source from Olympus, also discarded by another general surgical team. And then we have one cheap camera Escola also they don't use. And we have old Richard Wolf system, which is almost, I think, 10 years in our hospital. This is how I start in 2005. And we have a loan Esculap endoscope at that time because the Richard Wolf endoscope was very big. So only in 2008, we add on our Minop system and we have Castos. 8 years later, only I get my dream system. In other words, I have a Minop, I have not only Richard Wolf, but also Lota from the Esculap from the cranial endoscope. So now if you look at the endoscopic neurosurgical procedure, it can be divided into three. Endoscopic neurosurgery, or also known as channel endoscopy, is when you do endoscope, the scope actually as a primary visualization tools. And you work entirely through the endoscopic working channel. Okay, this is what I'm going to share with you in my entire presentation. But when you use a microscope as your primary visualization tools, and you want to look into a corner, for example, you can see this picture. After I remove the craniopharyngioma, I cannot see is there any residual tumor beneath the optic chiasma. Then I will use endoscope to see it as a secondary visualization. This is endoscopic assisted neurosurgery. Whereas endoscopic directed neurosurgery, or also known as endoscopic control neurosurgery, is when you use an endoscope as a primary visualization tools, okay? And then you use your equipment parallel to that. It is outside the endoscope. So means you can put your endoscope in one corner and then you have a lot of maneuverability. You can do bimanual technique because the scope just only for visualization. But endoscopic neurosurgery is a channel endoscopy is a very challenging because everything, even you have a many working channel, but your equipment can only come into one channel. So when you talk about endoscopy, actually you need a space. You have to work within the cavity. So you have an endoscope and then you need a space between the endoscope. So you need at least about maybe 1 centimeter or more so that you can easily work within that cavity. So true potential space is defined as a space which can be created without disrupting the normal structure or functional integrity of the tissue involved. It may be repeatedly created and obliterated without resulting in tissue damage or requiring tissue repair. This is a basic concept of potential space which is being used not only in neurosurgery but any other endoscopic surgery. You can use the cavity, you can create a space. For example, you do endoscopic carpal tunnel, you create a space. You do endoscopic thyroidectomy, you create a space. The space can be created. But in neurosurgery, it's slightly different. Okay, we have a very critical structure. We have so many wires, neuron cross all over. You cannot simply create the space, except you use some potential space which is available, or you can go through a normal structure which least risk when you create a tunnel for the endoscope. So the preformed space can be a normal CSF space, for example, ventricle, subarachnoid, or subdural space, or when you have a disease, for example, hydrocephalus, the potential space or preformed space has been expanded. So you got more space to work. This is much better. And hidden access, like using a natural orifice, like endonasal skull base to access the skull base system, is another potential space where you can do, you reach the skull base through the nose. So this is an example of a Sega in a 6-year-old tuberous sclerosis. So he was treated initially conservative because mom refused any surgery, but during follow-up, the tumor gradually increased and she developed biventricular hydrocephalus. You can see you got space. You can have a hydrocephalus and you got space, but you know that the tumor are very huge and very vascularized. So endoscopic neurosurgery alone, it is quite impossible to address this. But we use endoscope as a tools to visualize it as endoscopy assisted surgery. So we create a keyhole craniotomy. This is about 3 times 3 centimeter through a linear incision. So microscope first, we use, this is a blade, okay, and then we dissect the arachnoid. We go trans sulcus, yeah, we create a sulcus, then eventually we put an endoscope. So I hardly do this technique, but I want to see the tumor relationship between a critical structure. For example, like where is the location of the correct plexus and so on. But what I am trying to show you that with expanded space, you can see more, and then you can have a space to work. So this is what the channel endoscopy need. But unfortunately, channel endoscopy have a lot of limitation because the working channel are very small. Then you cannot do endoscopic neurosurgery for such tumors. So I use this just visualization. But what I want to share with you is by using a microscope have limitation. Okay, microscope can see in the line, along the line of sight. So it cannot see what is outside or beneath the area that you cannot reach along the line of sight. So you need endoscope. And sometimes that's why you use endoscopy assisted. This is just to show you that when you have a disease, you have a cavity. So by combination of endoscope, you can have a very minimal traumatization. So now a basic of principle of neuroendoscopy to see and perform gesture under visual control in anatomical cavity which are not accessible at glance, as I mentioned earlier. But the field are slightly different. It's a cone-shaped field. You have a blurring at the margin, which is a fish eye effect. You lost the stereoscopic view like microscope. You have a 2D images. So that's why you have to be trained to understand that. To understand the depth perception, you need to know the orientation of the endoscope. So what you hold is not what you see. So you have to coordinate. When you work with endoscopy, you actually need a very good colleague to work with you. It's not one-man show because you have to control the endoscope. You have to hold it at the same time. You have to do maneuver. Okay, the problem with the endoscope, you can only see what is in front of you. Okay, and then you have sometimes you have to understand the obliqueness of the instrument. The instrument will come straight into the working channel. Okay, and the cavity must be larger than endoscope. You cannot work, for example, like Chandel endoscopy in a small surrounded space because the surrounded space is smaller than endoscope. So the space must be larger than endoscope. Okay, so that's very important. So rigid endoscope you can see, but the flexible, I think Alberto have more experience in this. For example, if you go to the foramen Monroe, you must remember that as you bend your flexible endoscope, the shoulder of the endoscope at the back is touching the foramen of Monroe. So you have to be very careful. So you need to be familiar with the equipment that you have. Okay, the basic neuroendoscopic system consists of instrumentation, accessory, and visual system. This is a video endoscopic, it's a video surgery. So this is why we have in our hospital, we have a MINOC as our primary tools. But you need to understand what is, you must know your endoscope very well. You need to know the size, the diameter of the endoscope, the working channel, and from where the equipment move. You can see here, for MINOC, the lens is actually below and the working channel is on top. And you have a 2 working channel where the water in and out. So you need to know the length, the diameter working channel so that you can accommodate to the case that you select accordingly. And there are various telescope. You can have a 0 degree, 30 degree, 70 degree. But in my experience for cranial endoscopy, I only use 0 degree. But for 30 degree, usually for endoscopy assisted skull base. So 30 degree only selected cases because the 30 degree sometimes the tip of the shaft of the endoscope can be the telescope can be very sharp. So it can be, can cause injury to the underlying brain structure. You have to be very careful. You need to know your equipment well, okay? So this is a new endoscope from Escolab. They have an oblique, more working space. You can put 2 instruments. This is allow 2 instruments working through 1 working channel. So, but again, the movement a little bit limited compared to if you use the endoscopy assisted. So some endoscope, the camera is actually below and the working channel on top, and some endoscope, the camera actually on top and the working channel come from below. So you need to know your endoscope very well. So this is from LOTA. So you can see the camera is on top, okay? And the working channel is from below. So usually I like to hold the endoscope like a pistol, like that, instead of like that. So then you need to know the orientation of your camera, okay, the orientation of each hole. So when you turn the endoscope, so your working channel also turn accordingly. So this is, you need to know the orientation very well. That's why you need to know your endoscope also very well. So for me, channel endoscopy is a two-surgeon technique. Both surgeons need to use both hands. It's a four-hand technique, but only one captain. Okay, so in other words, for me, I would like to hold the endoscope because this is the most critical part. So when I hold the endoscope, so I would like to have my scope. Usually, I use right hand to hold my camera. Okay, left hand like holding a pen. Hold the tube of the endoscope, and then I use 3 fingers to rest on top of the skull, so that I can have a very good control. Okay, and then I will hold my hand on the other side to hold the camera, but make sure that I don't pull on the light source, because we have a young neurosurgeon who's so excited, they hold it like pistol, so they grip after long hour surgery, they grip the light source and it broken that. So you have to be very careful, and you must to understand your scope very well. Okay, so when you rotate, so there will be a movement. Okay, and your assistant need to know also. The second surgeon also have a hand that steer the equipment, and also have hand that anchor it, because your working space are very small. You can have maybe 5 millimeter or minimum 1 centimeter working space. If you don't control your equipment, it can go beyond it and it simply injure your structure. So this is why I say it has to be a two-hand technique. So bipolar, you need to know your bipolar very well. This is from Richard Wolf. So you need to understand your equipment very well. Usually I will orientate my assistant within the lateral ventricle, which is space much more larger. And I tell the direction according to the clock. If you can see here, the bipolar from the Richard Wolf, they are not 2 point like that. They are side by side. So I will ask my assistant that I want to go to 3 o'clock. So mean I hold my hand, I will push his hand, okay, like that. So he will use the bipolar, and then we coordinate the depth. And sometimes I say you stay the distance, so I will advance my microscope, the endoscope. Okay, sometimes I say you go in further, so I will keep my scope at that point, but the assistant will move the probe further. So you need to coordinate and make sure that you do not lose your orientation, because sometimes during the procedure, when you have a drop of blood, everything turn red. So if you lost your orientation, that's where the disaster start. So you need to know your equipment well. So this is a bipolar from Wolf, okay, and this is bipolar from Minop. So when you do endoscopy, most of the instrument, they are shaft instrument. You cannot use bayonet instrument because the working channel are only 2.4 millimeter. No way that you can use bayonet equipment. So shafted, okay, so you need to know the tip of the bipolar need to be seen. For example, like this, just now, I will ask my assistant to see the endoscope to put the bipolar at 8 o'clock. 8 o'clock mean 2 point must turn like that, so that in that direction. So he will twist the equipment so that we have exactly the point that where we want to control the hemorrhage. Okay, all right. So now it's a video surgery. Okay, orientation is very important. So must make sure that you and assistant have space. So some equipment, for example, like Minop, they have a very straight working instrument, and you hold like that. And then your assistant hand will be in front of you. So I prefer to have equipment with a flexible. The endoscope, you use instrument flexible so that it can be away from the hand of the surgeon who hold the endoscope. Otherwise, the assistant hand can be touching your face and you can't see. So that's why I like more flexible equipment in the working channel, but I only have a rigid endoscope. So that's why I would only talk about the rigid endoscope. So you can see just now, this is a colloid cyst removal. So what I want to show you, the importance of orientation. Okay, you need to know your bipolar tip position exactly so that I can burn the pedicle of choroid plexus that holding the choroid cyst. Then I can see the tip of the scissor. You must see the tip of the scissor, yeah, both sides before you simply cut. So you cannot cut in a blind end. Okay, so this is important to coordinate between you and your assistant. And sometimes when you do a more advanced technique, for example, removal of colloid cyst or removal of clot, so the working channel are very small. So no point for you to pull the tumor or the lesion into the working channel because it's gonna stuck there. So it will disturb or it will interfere with the working channel. Then later you have to flush. So you have to grab it and you have to take out together with the endoscope, okay, and then release the lesion or whatsoever, and then you insert it back into the tunnel that you have created before. This is also important because you have to instruct your second surgeon that you hold it, hold, and then just near to the endoscope, then maintain the suction or the grasp before you pull out. Okay, so this is a very important because sometimes the lesion can be very big and you have to cut it into smaller. We show some cases later. So this is actually, we use infant feeding catheter. So we connected to a suction that we control the pressure of the suction with one hand. There's a hole there. And then we actually experience a huge clot that impossible for the clot to go through to the tunnel. So now sometimes you may lose if you do a case like huge ventricle, for example, congenital hydrocephalus. So a small ventricle usually quite easy because, and you insert the endoscope, the light will be reflected, you can see the structure. But in a huge space, so the light will be dispersed. You can find like a darkness, and you can't see anything. So don't simply introduce, but you must go to the nearest wall. So you, like say you turn a little bit to one side, you try to find a wall so that the light are reflected, then you find some anatomical landmark, then before you go deeper and deeper. Don't simply go inside because you do not know what structure you are going. Try to find the nearest wall so that light can be reflected. It can be part of the wall. It is enough before you get into a deeper structure. So sometimes you can have this is actually another tools is by Sonoka Zoring. This is a ultrasonic, it's a QSA, endoscopic QSA you can use for intraventricular procedure. So, but unfortunately, this Sonoka can only be used in the gap. I was told that gap is no longer being produced. So we bought this in our department and we bought a Minop Intraven, but unfortunately it doesn't, the length are not enough. So that the Sonoka stuck within the ventricle, within the channel. So we can't use it. But you can use it for channel endoscope. For example, if you use a tube, then you can put scope on the side and you can use this Sonoka to side of it, then you can remove clot, you can remove certain tumor and so on. Okay, when you have hemorrhage, first, do not panic. Okay, this is ETV, supposed to be simple, and you start to see bleeding. Okay, so first you must instruct your assistant, do not panic, wait, stay where you are. Don't try to move, don't try to find here and there. That's why it's quite important. The most experienced surgeon for me will hold the endoscope. Okay, so when you have bleeding, usually when you do endoscopy, bleed usually from the epithelium, the ependyma, or from a vein, a very small vessel, which can be easily controlled by irrigation. So if bleed, you just irrigate. But in this case, I don't want the blood clot get into the prepontine system because I want to do ETV. So you can use a Fogarty catheter like this in this case to tamponate the hemorrhage. Okay, but because this is quite an important technique, you can adjust the balloon so that you can find and obliterate the source of the hemorrhage. Okay, so you, if bleed, you just wait, because let the clot form. Okay, usually I call it a blood cake. You wait for maybe 5 to 10 minutes and the clot will form, and then they will form like a cake. Okay, very long. You later when the clot form, then you can pull it together. You can get a better picture. So when you have hemorrhage, you wait. But sometimes I use a tip of endoscope to control the hemorrhage, or in the severe hemorrhage, I use tip of bipolar to cauterize it. Okay, so first, do not panic. Now we go to the second part. I will show you some of tip and tricks and how I decide my cases, so to get a better and good outcome. Because when I came back from Germany, all hydrocephalus I put ETV, but later we realized that some indication, even though written in the textbook, very good indication, but you have to judge based on your experience. Sometimes it doesn't work. Okay, so you have to have some experience, then you have to cater according to your local experience and local cases, because the result maybe varies from center to center. So now we look at the most important simple case when you have a natural anatomical space expanded by disease process, which is hydrocephalus. Okay, the best case for you to do is ETB. So we can divide the hydrocephalus for endoscopic procedure into 5 parts. One is monoventricular hydrocephalus. When you do imaging, you find that only one unilateral ventricle are dilated. Then you know the obstruction at the ipsilateral foramen or Monro. So you can use the dilated ventricle area as your potential space expanded by the disease, and you can do procedure, and you know the lesion targeted at the foramen or Monro. So you know already by looking at the CT scan alone, or you can have an MRI and so on. Biventricular hydrocephalus means you can only two lateral ventricle are dilated, means the obstruction has to be involved both foramen or Monro. It could be addition at both Monro, or could be a swelling or a tumor that cause obstruction at the upper roof of the third ventricle, which obstruct the outflow of both foramen or Monro. So you have two lateral ventricle dilated, but the third and the fourth are normal. Triventricular hydrocephalus, like this, you can have a third ventricle also dilated. This is a very nice case where you want to start your procedure like ETV and so on. Typical cause primary or secondary aqueduct stenosis, or you can have a pineal region tumor that block the outflow of the aqueduct. Then you got 3 ventricle dilated. And sometimes tetraventricular hydrocephalus, or sometimes people thought it's a communicating hydrocephalus, but when you do ETV, it works. It indicates that the obstruction at least at the foramen of Ruschka and Megendi. So if you do ETV, it works, okay, because it is obstructive hydrocephalus and the obstruction at the outlet of the fourth ventricle. And when you do ETV, the CSF will be diverted to the prepontine space as it cannot come out from the outlet of fourth ventricle. And the last classification based on the radiological characteristic is compartmentalized or multiloculated ventricle, where if you have a big space, then you can use your endoscope. There are various techniques that we show you shortly. Okay, ETV, first step, you need to know how to position the patient, where to place the hole, skin incision, opening, how to insert the endoscope. I will go slightly slow on an ETV, and later I will go very fast for other cases. Yeah. Okay, so initially I try to do ETV as many as possible, but lately I changed my policy. If the success rate is less than 50 or 60%, and you do ETV, then later you have to do shunt repeatedly, then I will do shunt. Okay, unless this is a tumor where you can remove and so on. I will look at cases where the high success rate of ETV, for example, like aqueduct stenosis or tumor-induced obstructive hydrocephalus and so on. So this is a typical triventricular hydrocephalus. You can see the obstruction there. Okay, so so usually I put the patient either horseshoe, or I can just put on headrest. Okay, so I will make a strip shaving. This is slightly, I think, about 12 years old girl. Okay, it's almost adult, so it's a big size. So I make a linear incision on the scalp, and then on the scalp and on the pericranium, I will make a flap. Okay, I make a flap and I push to one side, and then these irregular linings indicate the coronal suture. So this is a pre-coronal hole. mid-papillary line. I don't make any measurement, but I rely totally on the coronal suture. Okay, and then I make a pre-coronal borehole for ETV at the mid-papillary line. This is a standard for most ETV, but it can be varies from cases to cases, depending on the lesion as well as the radiological finding. But for beginners, probably you should follow the standard. You measure from the glabella and few centimeter from the midline so that you can get the location. So this is how I mark. It's a pre-coronal borehole, linear incision. When I infiltrate, I do not infiltrate too deep because I don't want my pericranial fascia to be disturbed. Okay, and then sometimes I use, if I want to put Omaya, or if I think the ventricle, the brain are too thin and chances of CSF leak is very high, I make a flap, and then even I make a slightly larger opening for the burr, and then I make a incision, a flap on the dura itself, then later you stitch, because they will avoid CSF leak. But if the brain parenchyma is quite thick, usually I use a sandwich of gel foam wrapped by Surgicel, and on top of that I put a bone dust to cover it. So then the second layer, the pericranial fascia, I make a flap and push to one side, okay, like that. Okay, so this is a linear incision. Then you can see the incision on the pericranial fascia. At the end of surgery, I will try to put a few stitches so that it helps to hold and prevent CSF leak after surgery. But if you do simultaneous ETV and biopsy for pinna region, for example, sometimes you need a second burr, which is much more frontal and lower part. So sometimes the burr can be on top of the forehead. But I learned the technique and trick from Professor Asser Peneski. So instead of doing that, he tried to compromise a middle way. So he made an elongated, slightly elongated burr. Okay, then you undermine the side so that your scope can go from this direction. Then later I will rotate the endoscope so towards that direction. So in fact, you can reach the pineal region tumor even in a small tumor using a single burr. Okay, so I still use burr because I would like to harvest the bone dust for certain cases, especially in adult. So you can see this is actually the bone dust that we put on top of Surgicel gel foam. Then only I cover the flap. So this is sometimes I do when the brain are very thin. So I make a flap on the dura itself, and then later we stitch. This is to minimize the risk of CSF leak. So how do I insert my endoscope? So I use pop pen first. I use pop pen, okay. Then I target to inner canter of the eye, of the EC lateral and the external auditory meatus. And then when I introduce my pop pen, I take a specimen for CSF analysis. And sometimes if the ventricle are small, I connect to irrigation system. I create, increase the preform space and make it larger. Then I ask the assistant to hold that. Then we remember the trajectory, and I put the endoscope into the trajectory that created by the pop pen. But you can see here, the assistant, I use three-way connector and connected to 20 cc syringe. So usually we use Hartmann solution, and I will ask the assistant to purge intermittently. So as you purge, they will create a space in front. So the endoscope will move step by step. So because I will chase the hole that created by my pop pen. Okay, sorry. So you can see here, this is actually we use this is actually from Richard Wu. You can see here as I enter the endoscope. So slowly the tip of endoscope hole goes, and I start to chase the trajectory created by the pop pen. And then intermittently, I ask my assistant to flash. It will expand the space immediately in front of the endoscope. Now I chase the hole, and then slowly as it's enter the ventricle. So you can see slowly and eventually it will get into the ventricle. So at this particular time, I do not start my irrigation first because I use the syringe to push it. So once you are in the ventricle, then only we start the irrigation. Okay. So once inside, you must find the anatomical landmark like this, correct plexus. Okay. And then the correct plexus will lead into the foramen of Monroe. The septum septal vein will be located medially, and the thalamus striate vein usually cross laterally. But you can see the thalamus striate vein a little bit oblique because this is actually a colloid cyst. It's disturb and distort the anatomy. You can't see the foramen or Monroe because it's completely obliterated by the tumor, by the cyst. But choroid plexus, you follow the body, the glomus, and go into the hole, and you can see two veins. This is a very important landmark, and the septum pellucidum in the middle. So I use Surgicel wrapped by gel form, and I cover it. But you must remember that if you have a very less brain, don't do this technique because sometimes your mini burger can fall into the brain. Okay, so you have to decide case by cases. So now I'm going slightly faster because that is a basic. So now ETV for congenital primary aqueduct stenosis. So I look at the ventricles. It's a very good case for beginners. Okay, so now usually I palpate the floor of the floor of the third ventricle, the tuber cinerarium. It looks thin, but in this case, it's not penetrable by Fogarty catheter alone. So I like to use a bipolar. Usually I touch it and then small bus, okay? And then I just make a small hole so that my Fogarty catheter can get into it, okay? So this is how I usually do, so that to minimize the risk of complication, because sometimes the basilar artery can be waiting down there. Sometimes you can have a prepontine vessel also just waiting down there. So you got to be very careful with your technique, okay? And then and so on, okay? But important thing, you must remember that the second membrane, the reliquis membrane, you can see here, this is the area that you need to fenestrate very well. So one of the reason for failure of ETV is because failure to penetrate the second membrane, okay? All right. So now you remember that the anatomy are very important. So usually I will find mammary body as a landmark, and the infundibulary recess, and the tuber cinerarium. This is a place where you want to do the ETV. And then the posterior part of the third ventricle, so the aqueduct osseous, posterior commissure, pineal recess, and then habenular commissure, and the choroid plexus in the third ventricle. You don't see this structure in ETV, but this is actually a colloid cyst, but eventually we may need to rotate it. But just to show you the anatomy of the fourth ventricle, because it is quite important, the anatomical landmark, especially in case of hemorrhage or distorted. So it's quite, it's an important guide. So how do I do my stoma? So I draw this imagery triangle, and at the center, I will do the stoma, or you follow the tuber cinerarium. This is like a comet heli, at the tail of the comet heli. But you must remember, you may have a bacilla. Sometimes you can see the bacilla artery. You can move further. But sometimes the prepontine space are very small. But I use the tip of bipolar. I palpate the clivus. Sometimes you can palpate the clivus, and you burn towards the clivus or the posterior clinoid. It is much safer, because sometimes you can have a very huge posterior fossa lesion that push your bacillar artery forward, and the bacillar artery can be just next to the clivus. If you do simple ETV, you can easily puncture it. So for such cases, usually I use tip of bipolar to palpate the posterior clinoid, and I make a burn, and then make a CSI go in, then the space will expand slowly. So that is another trick. This is I shown already. Okay, I'm going to skip this. So this is a very basic, just to show you the view from below. So sometimes you can have a very different anatomy. Okay, this is actually huge ventricle, congenital hydrocephalus, secondary to aqueduct stenosis. You can see a lamina terminalis. You can even do a fenestration to the lamina terminalis in this particular case. And you must remember that important structure that lies beneath that. Sometimes the floor can be very thick. For example, like this, patient with a previous hydrocephalus infection, many shunt done. Somehow the mother just refused for any shunt. They want us to do ETV. So ETV was done, but after infection, it caused adhesion again. And you can see here, even using a Foley's catheter, is quite difficult to expand it. So I have to use a special dilator to instrument to dilate it. But you can see here, what I want to show you, the position of the clivus. You can see this is actually the posterior clean-out process just now. So when I put my balloon catheter and slowly the space expand. So this is what I say for certain cases where the bacilla can be pushed forward. So you can use the clivus and tip of the posterior clinoid as a landmark. So this is a prepontine arachnoid cyst. So you can see here, it causes a very bad compression to the spinal brain and even the craniocervical junction. It's actually cause obstruction, and even it extend down to C2 and C3 junction. It's a very huge arachnoid cyst, prepontine, and the child come with progressive problem with walking, imbalance, and eventually unable to walk. So this is again a space that created by the cyst. So you can see the foramen Monro, and then immediately beneath that, you can see the tuberosinium almost thinned out by the expanding arachnoid cyst. So if you have a scissor, you can have a multiple hole. Okay, I usually use a bipolar to make a multiple hole, and I cut it so that I can enlarge it. But if you have a bigger working channel, sometimes you can hold it and you can cut at the same time, right? But you cannot use in Minot because Minot only have one working channel. So then once you go inside, you can see the valve effect of the arachnoid cyst. Then you have to fenestrate for the second hole so that you do endoscopic partial cyst excision, and you do cystinostomy. So you can see the third ventricle are very close to the stoma that you created. So later the post-op MRI shows that the lesion, the area are completely obliterated. Okay, so monoventricular hydrocephalus, this is example where you can use, this is more complex cases. I'm moving to more difficult cases, usually maybe for another level or even who has some experience before. So this patient had previous infection, shunt infection. You can see the tip of shunt actually adhered by the addition. So you can see the Monro are obliterated by purulent material. This is one of my first early experience where I was not brave enough to remove a pus in an inflamed foramen or Monro at that particular time. So what we did, we just do lavage. We make a septum pellucidotomy, as you can see here. So we make a dilatation. In fact, we make a few opening at the septum pellucidum, which are grossly thinned out and dilated. Then you can see just now the tip of the catheter at the back. So it causes communication between right ventricle to the left ventricle to the septum pellucidotomy. Then the shunt take over, to the opposite side. So the patient survive. We do not need any shunt revision. So colloid cyst is another challenging case. It can happen in elderly, adult, and young children. So you can see here. So colloid cyst usually when I make my burhole, I do lateral canthus burhole. Okay, it's a pre-coronal burhole. I make a burhole lateral, not at the mid-papillary line, because you need to go sometime through the foramen Monro, and sometimes you have to do septum pellucidotomy to look from the opposite side, and sometimes you have to push the colloid cyst from the opposite side back to the ipsilateral foramen or Monro. So I use, you can see just now, a choroid plexus wrapping the foramen or Monro. First, you must burn the choroid plexus because choroid plexus can bleed. So I use the infant feeding catheter. You can see there's a blue tag. I will ask my assistant, okay, move the blue tag to 3 o'clock position. They can aspirate the content. Now you must remember choroid plexus are wrapping the choroid cyst from both sides, from the contralateral ventricle, from the superior aspect of the third ventricle. You don't simply pull, because you simply pull, it'll bleed from the opposite side. Then you can't see. So you pull slowly, you can see the pedicle, you cut. This is what I say, assistant hold the cyst and you take over the cyst together with the endoscope. Okay. So this is one of a thick choroid cyst, but a very thin wall we can pull out. It's away from the choroid plexus and it comes as one piece. But you can't do this in every cases. You have to select. Not every cases you can do like this. Because you pull simply, then it will bleed from the choroid plexus. So linear incision, you hardly see the scar after surgery. Okay, when you want to do a simultaneous ETVM biopsy for pineal region for beginners, usually I advise that you look for a big lesion. I use interthalamic mass as my landmark. If the interthalamic mass, the tumor encroaching or crossing the interthalamic mass, pre-coronal hole works. You can do ETV simultaneously biopsy. In my center, during office hour, we even send a frozen section. Then we know the histology almost immediately. You can plan. For example, like this pineoblastoma, we do ETV and we do biopsy at the same time through a small incision. So this is a kid, 6 years old, post ETV biopsy, and then we just subjected the child for what they call it, chemotherapy and radiation therapy. So important again, just to show you the technique, the orientation. So you must see the bipolar or the biopsy forceps side by side. You have to rotate according to my orientation to the clock orientation. You can see here, so this actually my scope is like that, number 1. Number 2, number 3, I rotate the scope in that direction. So now you can see the stoma is at 3 o'clock, at 3 o'clock instead of in front. So then I go, sometimes you can sacrifice a very thin interthalamic mass, no problem. But if the interthalamics are very thick, try not to do that. So this is why I say if the tumor encroaching the interthalamic mass, you can easily do biopsy. Okay, all right. So I'm going to skip this. So pineal region tumor, you can see after biopsy, chemoradiation, it shrink within 6 months. So a small tumor, in our early experience, we use navigation to determine the best trajectory, as I showed just now in this slide. So I take a midline between the best trajectory for ETV and pineal region. So I use to rotate the endoscope in a different direction so that the single hole you can reach a tumor. For example, like in this case, so pineoblastoma. So this is a case of child who had a VP shunt earlier and subsequently have a pineal region tumor, a metastasis to the suprasellar area. So we do a simultaneous biopsy and subsequently we subjected the patient to chemoradiation. So compartmentalized hydrocephalus, so you can use endoscope, a rigid endoscope. You need to have an MRI. At least in our center, we want MRI. Then from there, you can pre-operative planning. You can decide the line of trajectory. So how much you can go. So you try to go along the best one line as much as you have to select the best trajectory that you can reach as much as largest trapped ventricle as possible. Okay, so you may do one direction, you may do another direction, but through a same hole. So this is actually a second part. The first part of the compartment is already removed, but there is another compartment below that. So instead of, you can see an incomplete septa, but I have to enlarge it. I use a bipolar and then just drag it and subsequently use scissor to enlarge it. Then we get into the ventricle, into the area, contralateral area, until you see the normal ventricular lining. So you can see just now. So this is one, and then the second trajectory. Actually, we go to on the other side. Then we make actually 3 trajectory to simplify all the compartmentalized hydrocephalus, and later we put one shunt, because in compartmentalized hydrocephalus you cannot get away without shunt. But fenestration, we simplify the area into as many spaces that can communicate to each other. Sometimes you have a shunt obstruction. This is actually child with intermittent suboptimal shunt functioning. So he had intermittent headache, so admitted to the ward, headache improved, discharge, and headache again. And then we decided to put a scope. You can see this is the reason why, the shunt intermittently blocked, because only 2 holes are open and the rest covered by the addition that formed. This patient actually had a previous infection, so you can see when you have a previous infection, a new formation of membrane can be easily developed. So you can use this endoscopic technique, scissor, cut, and remove it. Okay, so just to show you that sometimes when you have your shunt stuck, so this is actually a tip of shunt stuck to the correct plexus. When you pull, it bleed. So we luckily we decided to put an endoscope. We fenestrate and make the cyst collapse. Then we we cut, we disconnect the correct plexus, and we remove it, and subsequently we have to do a revision of shunt, because you can see here the correct presses and the addition is already clogged. The what they call it, the tip of the catheter. So now this is a rare technique. I only have one such cases, a 9-year-old boy who was playing football and suddenly hit by a spraying bullet. Okay, so you can see here, when you have a bullet, so the travels, as the bullet travels, they have a temporary cavitation effect. So as the bullet travels, it's actually create a passage. So we think that this is a potential space created by the bullet. So we can take out the bullet because the patient in headache, and the patient, even though have no neurological deficit, we don't want the bullet to stay there. And the patient, it is a low impact. I think it's it is not a very high blast injury. So we decided to use endoscope to take this bullet out. But you remember that when you have a foreign body, you cannot use MRI. So what we need a navigation for such cases. So we use a CT scan. So we mount our endoscope with the CT scan, with our endoscope with navigation system. So we can decide the line of trajectory using the endoscope. So you can see here we use a LOTA endoscope. We mount the LOTA with a navigation system. So the advantage of endoscopic technique in this, first you can debride the wound along the trajectory of the bullet. So we also not sure how the bullet looks like before we do the surgery. We use infant feeding catheter to take out the clot. So as you can see here, all right. And surprisingly, the bullet actually stopped 1 millimeter from the brainstem. So this patient is very lucky. So we take out the clot, then we see this abnormal strength. We do not know what is that. And the bullet is too big for our grasper to grasp. And so we decided to grasp this black thing. This is actually the patient's hair. So the patient's hair embedded with the bullet, so that as we pull the hair, the bullet come out together. So we are just, I think, very lucky. So not all cases you can do endoscopic, pure channel endoscopic to retrieve the bullet. You can see the bullet actually just the hair is actually brainstem. It's very close to the brainstem. So we take out the bullet together with the endoscope. You can see that. So, and the child, very active football player, he go back to the football field and play back the football. So this is another challenging case where we have case with hypothalamic hamartoma. Okay, so you can see the ventricle are not dilated. Okay, the space are very small. Okay, but you can use the preformed space to put your endoscope. So, but this is a very challenging. 4-year-old, the Monroe are very small, the ventricle are not dilated. So we decided that we need a navigation guided. So we use a navigation to mark the imaginary line of trajectory. We have to come from the opposite side because we want to disconnect the hypothalamic hamartoma so that the epileptogenic lesion will be discontinued, that it will help to eliminate the seizure in this case. So we mount the endoscope, but you must remember that as you put the endoscope, there will be slight shift as the water come out, okay? So, but if you can see here, the ventricle are very narrow and the Monroe are very slit. But you remember that ventricle are preformed space. So what I did, I put an irrigation Hartmann solution, maybe about 50 to maybe 60 cc. Then you can see slowly the space is expanded. Yeah, you can use the endoscope to slowly actually push the Monroe, but not too hard because it will cut the Monroe. You need to have a gentle traction. You can track the Monroe. Then you can see the ependymal lining are perfectly normal. Without navigation, I don't think I can do it safely. Yeah, so we know where is the target, and then we just disconnect it until we reach the area to the arachnoid area. But you can see here the problem with your endoscope moving into a small Monroe. You have to make sure that there are space for the water can go out. If your Monroe is too small, your endoscope goes there, and the irrigation system, and if your endoscope channel that for the water outlet is blocked by for some reason, so the water will be accumulated in the third ventricle. then you can have a sudden raise in ICP, then you can have herniation and bradycardia. So that's why very important for you to make sure that the space that you want to go must be much larger, slightly larger than the scope. So this is a pre-op scan, MRI, and 2 years later. So 2 tumor, you can use also the limitation with the endoscopic channel surgery. So big tumor is very difficult to remove. In my experience, I remove only small tumor. You can see here, this is actually, we go contralateral approach also from the right. First, we attack the thalamic cystic lesion. So this is a mural nodule in the thalamic cystic lesion. So once the thalamic cystic lesion collapse, then actually we go to the second tumor, which located between the floor of the third ventricle. So because this is a small tumor, you can use bipolar, cauterize it, and remove the tumor in piecemeal using a forceps. You can see like that, pre and post-op. Okay, correct process papilloma, very nice. You can see stalk here. So the plan is to burn the stalk really hard until there's no chance of bleed. Because you must remember, if you don't cauterize it well, the moment you cut, this is an artery. There's artery and big vein, and a major artery supply the tumor. If you don't adequately cauterize it, when you cut, you're gonna bleed. You're gonna bleed and you can't see anything. So we decided to find the correct places, and then we identify the pedicle. So where this most likely the pedicle goes, which is a huge artery and huge vein. So you have to cauterize that, and then subsequently once okay, then you cut it. And then the problem is the tumor are big. It's a 3 centimeter, and our tunnel are very small. In fact, we have to divide the tumor into pieces, and before we can remove with the endoscope, we withdraw the endoscope together with the tumor. This is a post-op scan. I think the last, because of time, maybe I just focus on one part, which is infective hydrocephalus. So I want to share this technique because it can be useful, especially in developing country or the area where you have a lot of shunt problem, shunt malfunction, and infection. So a case presentation, this is a 6-month-old boy, girl, I think boy, who has a prematurity intraventricular hemorrhage and hydrocephalus, VP shunt done, and the VP shunt become infected and subsequently develop pyogenic ventriculitis. So in our experience, in many years ago, pyogenic ventriculitis are very high mortality. It can go up to 70%. So most of the child, if they survive also, they have a lot of morbidity. So we have to find some solution how to address this. So you can see this pus ascending into the abdomen along the shunt track. So we remove the shunt, but before that we did a CT scan. The child has to be intubated because he came in sepsis. We give antibiotic first, we control it, then only we go in for what they call it, endoscopic lavage. So this is a typical epidermal enhancement. You can see here, all right? So we use bilateral technique, because if you use unilateral, sometimes you cannot see a pocket of pus, because in infective case, you must remove as much as infective material as possible, because if you don't remove, it will reaccumulate back, it will disturb with the shunt. If you shunt, the pus can be disseminated in the abdomen and it cause more trouble. So we use 2, what they call it, flap. So this is one example of the patient. So we use infant feeding catheter connected to suction tube. And this is a mistake. When you use lavage, you must make sure that the water does not spill onto the patient drape, because in children, for example, they can cause hypothermia. So you must make sure that they use impermeable drape, or you have to put sheet so that the water will get into the bag rather than covered into the drape that can cause hypotension. Okay, so we use the same technique like ETV, so precoronal hole. So you can see as we introduce the endoscope, we do not start the irrigation. So we aspirate and remove the pus first, because if you start the irrigation first, so the pus will start to move all over, then you lost your orientation. So you aspirate first, but you remember, as you aspirate, the ventricle will collapse. Okay, so you have to carefully aspirate, make sure that the infant feeding catheter are exactly touching the slough, and the way you control the aspiration also very important. You can see now the interthalamic mass. Okay, then we done once we have removed most of the larger component, then we start the irrigation because it's quite impossible to work in a collapsed cavity. So as you can see here, so as we aspirate the content, so we can even clear the pus that clog the aqueduct or sylvius. So in the early years, we just put an EVD and sometimes we try intrathecal antibiotic, but it doesn't work because pus, if you give antibiotic, it does not address the pus. You have to mechanically or aggressively remove it, and you have to replace the infected or contaminated CSF with another new artificial CSF like Hartmann solution and so on. Now you can see it is much clearer. Okay, so then at the end of surgery, we do on the opposite side. So you must, usually we go from top and then we go to the Monroe, okay, and then third ventricle, and then only we go to the opposite side. Okay, so go to the most dependent part. And there are various techniques that we modify using the endoscope. So you can see here, we use a gravity feeding irrigation. In other words, we put the Hartmann solution on the drip stand, we put it higher. So the positive pressure syringe, we connect it 20 cc and we flush as we need. So we use suction irrigation. You can see the infant feeding catheter are a little bit flexible. So we use the blue tag as our marker. So it's because of flexible. So in fact, you can what I call it fish biting. You can tap by controlling the suction pressure. So you can like doing a vacuum cleaner. So but you must be very careful. If too high suction or too deep, the ependymal will bleed. Okay, so you have to be very careful. So you can see even I slide it onto the Monroe and I slide it on the correct plexus. You see just now, you touch the correct plexus, is going to bleed. So removing of the debris on correct plexus also need to be very careful. So sometimes I use the tip of endoscope. I only use Minop in lavage because Minop has a rounded tip. So I use the tip of the endoscope and part of the telescope to sweep up. You can see now like elevate the carpet, it's elevate slough. You go from normal margin towards the abnormal margin. You can see then subsequently you can grab it with your forceps. So this is just a cup forceps and you can remove it. Okay, so this is how we can use in endoscopic lavage. You can see here pre-op and post-op and the child after 3 months follow-up. So do we have more time or should I conclude? Shahid?
Yes, sir. How long more? One, sir? Maybe 5-10 minutes. You can say more, sir.
Okay, I think I will conclude. Okay, maybe one more and then I conclude. Yeah. Okay.
Sure. Thank you,
because this is important. When you have, then we expand our indication to recurrent shunt malfunction. We have a problem with repeated shunt, sometimes because of protein high, sometimes there are infected debris. So if we have a case in our center, child come with a repeated shunt revision, and if we tap the CSF, high proteinaceous material, so we advocate lavage as an adjunct prior to shunt. So it will, you can see here, this is as we insert the endoscope without irrigation, you can see a very oily, high proteinaceous material. You can see a lot of what they call it hemosiderin that cover the surface of the ventricle. You can see Monroe also a narrow slit, oblique-like, because the wall of the ventricle become very stiff. This is the reason why you have a slit ventricle syndrome after infection. Yeah. By using endoscope, you can see as you continue irrigation, just irrigation, okay, you can remove all this high proteinaceous material. You can see the foramen Monroe, it was initially oblique and narrow and start to open. And you can see even part of the hemosiderin material start to float. So you can remove it. So that means that you have removed the high proteinaceous material. So your shunt survival will be longer. Number two, you have removed all this material which can block the shunt. Not only high proteinaceous can clog the shunt, but also all this debris can block the VP shunt so that you can irrigate it. You can see the difference between before and after. If we are in doubt, we put an EVD, and then we put the patient for VP shunt as early as possible. Okay, but at the end of procedure, if we find that, for example, like this, you can see very clear, very nicely clear, then we shunt straight away. So it depends on cases. You can see before and after, of endoscopic lavage. So I'm going to the conclusion slide. Okay, so this is a take-home message, I think, for beginners. Okay, number one, neuroendoscopy is a video surgery. I remember Professor, I think, Gotsenowitz shared his experience, not his experience, but a real story in Europe, where a neurosurgeon doing ETV, and then he performed exactly according to what he see on the monitor, and he thought the surgery went well, but the patient developed bradycardia and died. Okay, then later they realized that actually what he see is a recorded video of the previous patient. It was timely done in the such a way that assistant third, maybe he say record. So the assistant play the video, and it was so nice so that he just go in, actually his endoscope get into the brainstem. So the patient died. Okay, so this is a lesson learned. And beginners usually they're so excited, they want to do ETV, they want to see the balloon, they don't check the equipment. So when inside they realize the bipolar doesn't work, the balloon ruptured, okay, and the catheter blocked. So you must check your equipment. It's a video surgery. You depend on the monitor. You need a good monitor system. Check your equipment. You must familiar with your equipment. Number two, you must master the anatomy, not normal anatomy, but endoscopic surgical anatomy. The anatomy that you should see when you do the procedure through the endoscope. Okay, so you must familiar that. You need to know what is normal anatomy. You need to know the landmark, because in case bleed, you find the landmark. For example, if you lost, for example, you have pyogenic ventriculitis, slough everywhere, you find the anatomical landmark, interthalamic mass, choroid plexus, foramen or Monroe. This is all are important, okay? You must remember there are congenital variation. So in my experience, not all ETB are same. Some congenital patient, you go inside, you do not know what is the anatomy at all. Okay, it can be still a continuous learning process. It can vary from patient to patient. And in case of distorted anatomy, you need to know your limitation. Okay, so beginners, there are many steps. During our time, endoscopy was quite new, but now endoscopy is quite well versed. But in my department, even I don't do much more endoscopy, because most of my specialists all can do endoscopy, and registrar also can handle some part of endoscopy. Okay, but some center, how I learned, I went to Germany, I learned in the laboratory with a cadaver, and I go many courses, I go using a model. So, and I start with a simple case first, ETV, intraventricular hydrocephalus, get the result first, and before you move to another challenging case. So what I show you is past 15 years experience, but despite that, I'm still learning. So start your case in gradual fashion, and you must audit your outcome. Okay, this is very important. And finally, complication can happen in endoscopy. You can, you do a laparoscopic or OGDS, you can use your camera, you can wipe your tip of camera on the gut, no problem. But you cannot wipe your endoscope on the brain, because it will cause damage and all are critical structure. Vascular injury rarely happen. Vascular injury only happen in choroid plexus vessels, or if you go to wrong trajectory, you get to the basal ganglia. It happened to me once, but lucky it's no vascular injury. It can happen in basilar artery, especially when you do simple, so-called simple ETB. You got to be very careful. Raised intracranial pressure can happen if you don't check your outflow, electrolyte imbalance, and technical failure, as I mentioned to you. So thank you for listening. So I hope I don't overshoot. So back to you, Sachin.
Yes, that was definitely an excellent presentation, Professor Razmi Alias. Was those tips and tricks, whatever you given, were definitely useful, and those two weird cases which you showed, the removal of the bullet with the endoscope and management of the pyogenic meningitis, the technique, the low-cost use of the feeding tube, infant feeding tube, that is definitely very useful. So I think now we can have the session open for the panel discussion, and we can start with the expert comments of Professor Dev Pujari and Professor Alberto. I'm sure he's going to have a parade of questions for Professor Azmi Alias. Over to you, Professor Dev Pujari.
Azmi, I must say that you really covered the topic quite thoroughly, because looking at your title, I was really worried uh, how much is possible to cover, but you have tried to cover almost all aspects of endoscopic surgery for CSF spaces. And I think the only thing which is not covered probably is the arachnoid cyst, but I'm sure there will be another time for it. Uh, I think there are two or three most important lessons which Dr. Azmi has talked about. Know your instrumentation well. Everybody can't have everything, so you make your innovations. Like a couple of them he has already shown. Uh, the endoscopic lavage looks very nice when Azmi shows his videos, but may not be so easy to do. I mean, you can just get lost. So be careful and be persistent. I think these are the two issues I would say. About the use of two burr holes or a single burr hole, I think it largely depends on the size of the ventricles. I think if you have large enough ventricles, you can probably manipulate your scope. But if the ventricles are not very large, it may still be worthwhile rather than an in-between burr hole to have two separate burr holes. That is what I personally feel. The other thing which determines the need for one or two burr holes is also the thickness of thalamic connection. I mean, people have actually said that it can be cut, etc. But when there is a thick interthalamic connection, it becomes a little difficult to just, move your endoscope behind and do the biopsy. You have to many a times go from above the interthalamic connection to get a proper angle to get a biopsy. So I would uh, look at that very carefully before I decide one way or the other. Besides that, I think you have really covered it very nicely. One thing which probably need to be emphasized a little more uh, is how do you penetrate the third ventricular floor? You have been warned enough, but I think there are still people who feel that it is probably easier and use a monopolar diathermy and would coagulate the third ventricular floor. I think that is definitely not on. I would say that you can use that probe or cannula or whatever you call it, probably to make the hole, but you should go with a blunt instrument and you should try to see your penetration rather than use cautery over there. uh, Besides that, I think the talk has been very, very comprehensive, and I must appreciate Azmi's teaching for this work. Thank you.
Thank you, sir. So maybe I would like to respond on the ETV technique. But you can see I use a tip of bipolar to palpate rather than to simply bust. And when I bust, I make sure that the bipolar pedal is on my foot. I hold the scope and the bipolar pedal on my foot. So I will guide my assistant to hold the bipolar, one as an anchor, one to steer. Okay, and then I need to see the tip, and then I move. I move my endoscope to along together with the assistant to palpate it. Then I make short bust. Okay, that short bust just to make an opening. If I can just puncture it with the tip of bipolar, I will do it. So the one that I show, even I use a Foley's catheter first to palpate. It is a very, looks thin but very hard. So we use the bipolar also, it cannot penetrate, so I make short bust. So that short bust, we create a hole. We hope the CSF will go inside and will create more space. Then only I put my balloon. Because we don't have much option, we just use whatever we have.
I probably should also clarify my comment. I think there is no unipolar to be used for sure.
Yes, sure.
No unipolar to be used with energy. And if at all we need to, you can probably use bipolar. But many a times, if you do a corkscrew kind of a motion of your bipolar probe, you can get in.
Yeah.
When you have an opalescent membrane, when you cannot see behind the third ventricular floor, then it really becomes a problem. Then I think you need to have two things. You need to have a T2 weighted sagittal image to make sure that you have enough prepontine space in front of the basilar artery. And then if you have already seen that, you can go probably, you you can use palpation of the clivus as your navigation before you actually penetrate. And these two tricks work if you really want to do it, but better to avoid it. And those who are fortunate enough to have a thulium laser can probably do it with laser.
Yeah, very good comment. I agree with you.
Roberto
Thank you
is
very
going
much,
to tell us
Professor
something more.
Alberto.
Yes. Well, Asmi, you made a really excellent presentation about intraventricular endoscopy. Really amazing. I think we should thank you for sharing your huge experience. You showed so many interesting cases. I also, as Sachin said, was very interested in the bullet that you removed with the endoscope. And I don't know if you published that case, but if you didn't publish, you should definitely publish, because it is very interesting. Anyway, I think a number of comments can be done after this presentation. Probably there are some messages and comments I would like to share with all of you. The first one is that from your presentation, we learned that with endoscopy, we can manage a number of cases, a number of pathologies. It's not something you use only for ETV, but we can actually use endoscope to minimize injuries and due to neurosurgical approach. Second, I think it is very important what you said about the fact that the second operator, your assistant, plays a very important role in endoscopy. When I see the residents in my department assisting microsurgical procedures, I often see when the main part of the surgery starts, they just stay apart and look at the monitor, at the screen. And because, it's not always like that, but very often microsurgery is standalone surgery. So the surgeon plays by himself. This is not the case in endoscopy. In endoscopy, your assistant is very, very important. And I think in this sense, it is also useful from a training point of view, right? So if you can practice a lot as assistant during an endoscopy, you can really learn a lot. You mentioned about the flexible scope. You know that I am more familiar with flexible endoscopy in the ventricles rather than rigid. Of course, there are some pros and cons for both tools. I want to bring back the topic just mentioned about the adhesio interthalamica, the interthalamic commissure. With a flexible scope, for example, that is not a problem. We never damage that commissure. And also about the problem of 1 or 2 bar holes. With flexible endoscopy, I always use 1 bar hole, not 2. But of course, flexible endoscopy has some problems of vision and also less tools that can be used. I would like to know from you, how do you, if you try to look forward, okay, to the future of endoscopy, what do you see? I want to specify better my question. My feeling is that there is really a huge possibility to improve instrumentation, to extend indications. I really feel that endoscopy for neurosurgery is way back compared to the technological advancements in the recent years. I mean, I really think we have so many possibilities. I'm thinking about coupling endoscopy with robotics, for example, or, you know, improving tools. Yeah. So my question is, what do you think endoscopy, ventricular endoscopy, will look like 10 years later or 20 years later, as we are talking with young generation neurosurgeons?
I think you make a very good comment. I agree that flexible endoscope have additional advantage, in fact. But the drawback of flexible endoscope in the initial year, mainly because of not a good optic. Yeah, it's a very blur, and the working channel are very small. And then even you have a biopsy forceps also very small, because the scope has to be moved, and then the working channel also are limited. So then you can only do biopsy. Compared to rigid, they have a bigger working channel. So if we can have the problem with a rigid endoscope, the equipment are only one way, you know, like playing a snooker. So so you cannot maneuver. Yeah, you can see, but you move in that way that you have to move the endoscope. Flexible, you can direct your target. Yeah. So if we can have a very good optic flexible endoscope, and maybe a larger working channel, and with instrument that not only can cut, but also can cauterize and biopsy, maybe same instrument or maybe less instrument. Now you can see the company provide like a scissor many type, you know, but at the end you only use one or two, because it's a redundant. So either for marketing or whatever. But if you can have a technology where you can have a wide varieties of maneuverability, better optic, and what they call it in collaboration with technology development, which include robotic, which include navigation, maybe artificial intelligence. Okay, then we can use endoscope in many cases, you know, not just like what I show. So I agree. I think in future, so that will be in the pipeline. People now are very busy talking about AI. I think AI definitely in. Navigation is already there, but I hope that I personally can have a flexible endoscope with good optic and good maneuver in terms of the equipment. So I think that is the future should be. I think it will happen in 5 or 10 years time. I believe that will happen. Yeah.
Thank you, Asmi. Well, actually, a small part of this future is already here, because you know that Olympus also starts already produce the flexible scope with a chip on the tip. So you can have a very good vision. Unfortunately, in the European Union, it is not possible to use those endoscopes. I don't know if in your countries it is possible. If it is possible, I am very envy.
So it has to go through to the special division in the ministry. Right. First, if the technical and engineer says it's safe, then only we can bring in.
It is possible in India. One of our colleagues is using it in Hyderabad, but stores is not ready to sell it yet. But I think, Dr. Azmi, I feel it will not be artificial intelligence. Artificial intelligence will probably work. You can probably, you know, send drone cameras through the flexible endoscope to visualize all corners and whatever you cannot see. But when it comes to, even if we have robotic micro manipulators, we will still need a human intelligence to, take the tumor out and make the stomies. I think the human intelligence will at least work, if not our hands.
Yeah, completely agree. So we have a question from the chat, is it? Chat box?
Yes, so we have the members of Young Neurosurgeon Forum of WFNS and Young Neurosurgeon Committee of ACNS in the panelist list. So maybe we can have the question from them. Dr. Liu is there. Liu is the chairperson of the Young Neurosurgeon Committee of the ACNS. Dr. Liu?
Hello, hello. Thanks, Prof. Asmi,
Hi.
for a very nice presentation. Thank
Hi,
you for
Leo.
giving a chance to ask question. I have a two question here. One is, do you think that for beginner who doing intraventricular endoscope procedure, IGS usage of IGS is become very important. It will avoid any mistake, especially during the first few surgeries. The second question is, in the era where we can get a 3D MRI, what your opinion where we have been used to the view of opposite direction where it's more of a radiology imaging for axial, coronal, and sagittal view, which are not so endoscopic friendly. And do you think that there is now a trend using a 3D MRI in planning of surgery, especially related to endoscopic surgery? Thank you, Professor.
Yeah. Okay, thanks for your question. I think both question one, IGS, number two is imaging, are very important at the preoperative planning. So once you go in and it's all depend on your experience and skill. So because IGS has a limitation, you can see just now, I use IGS in my first early experience in ETV biopsy. Okay, for pineal region tumor, which is located posteriorly. Okay, but during the surgery, you still have to depend on your maneuverability of the endoscope. Okay, but it will give you idea what is the best trajectory so that once you can make a perfect behold. Because Pernesky in his lecture saying that actually a craniotomy is a combination of multiple behold. So if you can find the perfect location of behold, you don't need big craniotomy because the keyhole concept means you work in a distance. Okay, so you can have an angle. Okay, so I also use IGS, for example, when I'm not so sure like the trajectory of bullet. Actually, that case I presented in Krakow, Poland, and I asked anybody want to take the bullet. 100 participants European, they said no, they should not. So and then I showed the case. So that was in 2013, I think, long time ago, 7 years ago. I hope I'm actually waiting for another case to come, but no, but maybe we publish later. 3D MRI, yes, is important for pre-operative planning. You can simulate for young neurosurgeons so that they have some ideas because 3D MRI colonoscopy all has been done. Like what Alberto mentioned, that we are actually fall backward in terms of endoscopic technology. We should use preoperative MRI, the new technology, for the young people because young people are very good in technology and they like to play more video and so on. Maybe their orientation are much better. This is just to have a mind map and control. But the best actually training is on the patient. But the problem is nowadays it's not easy. Medical legal case are increased and so on. So you need a very good mentor. Okay, you need a very good mentor who can guide you. But as a mentor, we must know the limit so that at one time we think you are safe, we let you free. So this is what I did. Now, for example, in my center. So lavage, I don't do anymore. So I have a few people who can do lavage. I can just close one eye because they tag with me many times and I show the technique. I ask them to learn how to treat complication and be responsible. So by giving way, then empowerment so they can move. But of course, you have to control. If any problem, then you still have to be responsible. So I think, I hope I answer your question. Both are very important in pre-operative planning. Yes, there is some role.
Thank you, Professor.
So, but you don't have navigation doesn't mean that you cannot do ETV. but your limitation in terms of what other lesion that you can do with the endoscope.
Thank you, Professor. I completely agree with you. Endoscopic neurosurgery is one field where mentorship is very important. You can't just see and learn it on yourself. You have to have hands-on under some trained supervision. Then only you can learn it. Because any mistake in endoscopy can be a very big disaster. That's what. So, any other questions from the panelists? Beverly is here. Beverly is the member of the World Federation of Neurosurgical Society Young Neurosurgeon Forum. Beverly?
Thank you very much, Sachin, for this excellent talk. And thank you to the speaker for an excellent presentation. My question is about, apart from the infant feeding tubes, which are the low-cost adaptations do you recommend in endoscopy surgery?
Again, what the cost is it?
What
No,
other?
I was listening to your talk, and I was really impressed by the use of the infant feeding tube because of its ready availability in our hospitals. Which other low-cost adaptations do you use in your endoscopy surgery that we could adapt and that are easier to get in our settings?
Yes. So in fact, we come out this innovation under desperation, because we have a very high mortality from our, what they call it, pyogenic ventriculitis, because I did a prospective analysis. When I came back, I was asked to take care of pediatric, and I found that many shunt infection and pyogenic ventriculitis majority died. So we have to change our technique. So we have no option, because ventricular catheter that in the market was very expensive. I think at that time, something like 1,000 US or something like that, or maybe more, less than that. So then we use infant feeding catheter sometime for EVD when we run off of EVD supply, or we don't have money. So then we decided that the infant feeding catheter can be cut. So I didn't show in detail, but you can cut in a different way. Number one, you can cut straight, okay? But you know the feeding catheter, they have hole at the tip. So you must cut proximal to that hole. Otherwise, the water or whatever will come through the side hole. So you must cut proximal to the hole. When I cut straight, I use straight if I use for lavage, PAS, and IVH, intraventricular hemorrhage. Or sometimes when I do any endoscopic procedure, it end up with complication. So I remove the clot using that, because the infant feeding catheter will be connected to the suction. So you need to find a very sucker which the tip can plug into the proximal part of the infant feeding catheter. If loose, then whenever you put your pressure, it will not suck. So you have to be snug tight, yeah. And then the the catheter goes down. Okay, the second one, I cut. I cut slant. Okay, I cut slant with a blue tack on the top. So the blue tack will be the tip. The tip. When I use slant, when I do fenestration in colloid cyst, because what I do, I make a perforation using bipolar, small hole, then I use the sharp point of the slant cut feeding catheter to get into the cyst. Then only I aspirate, because I don't want the cyst content to be spilled into the ventricle. So I cut straight or I cut slant, and the indication, as I mentioned, it's a very cheap. It's only about, I think, 2 ringgit in our local money, maybe a few cents in US or something like that. It's easily available. Actually, we steal it from our pediatric ward when we started it. So, but you need to know your endoscope caliber. And there are infant feeding catheter which are very soft, so very difficult. If it's too soft, then you cannot suck. It will keep moving. So, but if too hard, and it can be damaging. So you need to find, I think, if I'm not mistaken, 8 French, and it can be blue or green, but it has to be slightly flexible. This is what we use in our center. Plus, the infant feeding catheter, majority are transparent, so you can see the content. Okay, and the tag you can use as a depth. So this is why it is easily available, and you can get it anywhere. And for balloon, we use Fogarty catheter that used for embolectomy. So this is all cheap, can easily available. So you can spare your money for that. So I hope I answer your question.
Brilliant. Very, very good answers. Thank you.
Thank you. Thank you. So there is a question from the chat box.
Yes.
What technique do you use in trap fourth ventricle? Okay. So we try many technique. We have tried endoscopic fenestration, but I don't use catheter to put in the aqueduct. Yeah. So if trap fourth ventricle, sometimes the aqueduct can be large. So I will try to fenestrate the area if the fourth ventricle are large and it can get through my endoscope. My endoscope is 6.4 millimeter. So if it is too small, I dare not to try. So sometimes we did ETV, and if they still cause compression, we embark on large surgery. So in which we do posterior fossa, craniotomy, and we do standard, technique to release it. But maybe Alberto has his experience because in attenuated trap fourth ventricle, so you need to release the outlet of the fourth ventricle, which is the Magenda and Lushka. Yeah, so with a rigid endoscope, it's quite impossible to do. Maybe flexible can do. So Alberto, can you comment on that?
Yeah, well, actually, sometimes I did this kind of operation with a flexible scope. You can actually enter the aqueduct. Of course, I discourage doing this if the stenosis is too long, because you can damage the periaqueductal gray matter. But if there is like a aqueductal obstruction due to a membrane, for example, you can very easily fenestrate the membrane and enter the fourth ventricle with a flexible scope. In that case, you can either do a third ventriculostomy if the outlets of the fourth ventricles are obstructed, because you already made the fenestration of the membrane at the level of the aqueduct, so you can do ETV. Or if ETV, it happened to me 3 times, ETV was considered too dangerous because of the position of the tip of the basilar artery, and then the enlarged fourth ventricle pushed the brainstem all the way against the clivus. So I had no space at all to perform ETV. So in those cases, I did Magendiplasty and Lushkaplasty. So you can get them patent again with a flexible scope. Yeah. In some cases, we leave, especially in pediatric cases, we leave a catheter, transaqueductal catheter, sometimes, not in adults, for sure.
Thank you. Thank you very much, Professor Alberto. I'm sure you are the next future's happening endoscopic surgeon.
Sure.
I'm really impressed with the thought process you have, the kind of calm and compose, and you're thinking. To have a futuristic approach in the endoscopy with the artificial intelligence and with the, it's phenomenal. Really, you're really inspiring.
I am still, thank you very much, but I am still a young neurosurgeon.
Young is just a number.
Yeah, right.
Any other questions from the panelists? Ridab, Mansoor, Idris. If no question, I have one last question. If after that there are no questions, then we'll wind up. So Professor Azmi, what is the cutoff of the thickness of the mantle you follow at your institute to do any endovascular in any endoscopic or a shunt? I mean, textbook teaching, if anything less than 1 centimeter, it's not good prognosis. One thing, and that is a good question.
Okay, it's a very difficult to answer. It depends on your community and the way you practice. So of course, for therapeutic purpose, so if it is hydranencephaly, whatever you do, it doesn't change the outcome. Yeah. But in our country, sometimes the parents want at least something to be done. Okay, so
Yes.
for that reason, we put palliative shunt. But the problem with when we start to bring this kind of patient, so post-op they need ICU, and then most of the time, sometimes they have problem with over drainage. Okay, so we have to really sit down with the parents. So anything that less than one table thickness, okay, cortical thickness, then we will not offer surgery, provided other structures are abnormal too. Okay, but if the frontal cortex are thick and the family and the child also diagnosed early, okay, and then the family are committed, then probably we will offer at least VP shunt. So I do not do ETV in young children less than 6 months because of personal experience. Last time we tried 3 months, and then they tend to close back, and then eventually you do re-ETV, and then they close back, and then instead of doing ETV as a minimally invasive procedure, but it end up with ETB with fusion. So it wrap up the so-called minimally invasive. So but above 6 months, probably I would offer. But it also depends on the underlying, if the patient have congenital hydrocephalus associated with intraventricular hemorrhage, associated with infection, then chances of having a chroma closure and failure is high, then I prefer shunt. Okay, so hydranencephaly, mainly palliative, very selected. We have to really to sit down with our support service. The intensivist sometimes not happy because there are many other cases that cannot get into the ICU, but once you shunt, they come with a lot of other complications. Subdural hemorrhage, shunt malfunction, and majority hydranencephaly, or sometimes this child, their immune system are down. So they have a tendency to develop more complication after the procedure. So but there are cases where I offer ETB CPC in hydranencephaly, but selected cases, but their parents happy that the head size is shrink. So they have so-called quality life with the child. But they know the child life is won't stay long. So, but at least they can spend time. So we respect that too in our community. So it depends on the how we approach, and we discuss with the family, and your support team need to understand. And sometimes our support team will say one way ticket. In other words, we give you this time. Whenever next time you have a big complication, then we give less priority because more other patients that need intensive care and so on. So we have to tell the parents, if they agree, then only we engage.
Thank you. Thank you. So do you always do CPC in the cases when you're doing the ETV? Because what I feel is whenever you are doing the choroid plexus cauterization, choroid plexus is making the CSF not just as a quantitatively, but qualitatively also. Did you ever find any difference in the chemical composition of the CSF, or any change in the cognitive pattern after in those patients which you've done the CPC?
Yeah, after you done, because I abandoned CPC more than 10 years ago. So only during my early experience, because we see more complication but less benefit. Maybe our experience outcome is not same like what described by Ben Waff. Maybe our population have a lot of more infection and something like that. So yes, when you cauterize the choroid plexus, there will be a lot of debris. Okay, so then you have to do lavage. So when you do lavage, sometimes at the end of the surgery, you will see the subdural space are expanded. So you solve the problem with the ventricle, but you have a problem with the subdural space. Then we have a few cases where they develop recurrent subdural hemorrhage. So then we have to remove the shunt, put a hole bilateral, and then it end up with managing a complication after that. So sometimes we just leave it like that because we know whatever you do, the brain will not grow, especially in hydranencephaly. Okay, this is compared to other hydrocephalus with thickness, then good front cortical thickness, then we're more aggressive on that patient. So I don't practice anymore ETB CPC. I think last 10 years at least.
Thank you. So any other questions from the panelists?
I think I'll just make one comment. It's not actually the cortical mantle or the size of the hydrocephalus which matters. I think what matters is if you have a normal Garel pattern and I mean, there are newer and newer measurements. If you look at new papers coming out of Abhay Kulkarni's analysis of all this infant hydrocephalus work, you would find that it is actually not the ventricular size, but what happens to the brain volume. And that is something which is not regularly being measured today. And therefore, to give up on a patient if he has otherwise, I mean, in a post-hemorrhagic, post-infective patient, we know that there is going to be some suffering. But I wouldn't never refuse an aqueduct stenosis patient just because the hydrocephalus is very large and cortical mantle is compromised. Um, and about CPC, as the experience is not uniform, and what Azmi says is absolutely right. Today, I think most of our Japanese, South American friends are doing CPC mainly for hydranencephaly, so that you do not have shunt complications. Then, whatever life the children have, they can live that without further suffering.
Thank you very much, Professor Dev Pujari, for that comment. Any other question from the panelists? If there are no questions, then we can wind up. Sure. So I'll just make a final remark. Thank you, Professor Razmi Alias, for the phenomenal lecture. I mean, you tried your best to explain. You made fantastic diagrams, some cartoons, and tried to explain the concept behind the endoscopic surgery for the young neurosurgeons. You showed beautiful parade of the cases, including those two weird cases of bullet removal with the endoscopy and your exclusive technique of using infant feeding tube for the treatment of pyogenic meningitis. I'm sure we can have you in the future to have more and more learning from you. And thank you, Professor Dev Pujari and Professor Alberto, for chairing this session. You want to have any final comment, or we'll wind up?
Some futuristic comment from Alberto.
I think we already heard so many wonderful cases and tips and tricks from the masters. So nothing else to add, I think. Thank you very much.
Thank you. Then we'll wind it up. Thank you very much.
And we take group photos, Sachin.
Sure, I've taken many group photos, sir.
Okay, very good. Please share.
yes, I'll share. Thank you. Thank you very much.
You ask me soon.
Yeah, thank you very much, Prof. Jupajari. I will try to contribute as much as possible in the neuroendoscopy committee.
No. Thank you very much for all your efforts, and I'm sure we'll see each other soon.
Yes. Okay, take care. Bye-bye.
Thank you. Thank you very much.